Okay, so hello everyone. So I've introduced myself in the previous session and my co-moderator. Would you like to?
So I'm
introduce yourself?
Zulueta. I'm a pulmonologist. I'm helping Dory, the moderator. I work here at Morningside, Mount Sinai Morningside, and excited to be here with this fascinating panel.
So can we just do a quick introduction of the panelists?
Yes, Sam Aguayo. I'm a pulmonologist, Phoenix VA.
Matt Cham, radiologist, University of Washington.
Hi, Tim Harkin. I'm Director of Interventional Pulmonology here at Mount Sinai.
I'm Kazerooni. I'm a cardiothoracic radiologist at the University of Michigan.
Vliegenthart, cardiothoracic radiologist in the Netherlands.
Okay, so this is the fourth time I'm doing it, and I hope you like the cases that I picked up. So this time I chose cases that reflect the cardiac aspects of the current meeting, or the cardiac focus. So these are the panel members. And I would just like to explain how we're going to do it. So you have to take out your cell phones and either scan the QR code or go to the website and put in the code. You will have this on each question that I will ask you to respond to. So if you miss it, don't worry, you will have it on other slides as well. So I will give you a few seconds to get ready. So, okay, all the panelists can do it as well. Okay. So everyone's ready? Okay, so the first question is a test question. Please choose what is your country of residence, USA or something else. So good for you. So 94%, as you can see, 90, now it dropped to 90. Live in the USA. Okay, so, right. So the USA goes down, they were quicker, right? The Americans were quicker. Okay, so we go on to the first actual case. So the first case deals with coronary artery calcification. So we spoke a lot about this. So now you get to test your abilities. So this was a 78-year-old male who is a 20 years participant in my lung cancer program in Israel. As I told you, I started after coming back from Cornell, from New York. I started the first lung cancer screening. So this is a recent study done in July, about a little over 2 months ago. And here you can see on the left the first low-dose CT screening that was done in 2004, and you can see how the coronary artery calcification increased with the years. And on the next will be a video of his current low-dose CT, and I will ask you to grade the calcification, so look carefully. Okay. Okay. So this is the question. How would you grade the coronary calcium in this case? Is it mild, moderate to severe, severe, or you cannot tell? Okay, so most people, okay, it's going a little up and down, but about half of you, 52%, think it's severe calcification. And then the next question is, how often do you assess the degree of coronary calcifications in your lung cancer screening studies? Okay, so I would think
A lot of pulmonologists there.
Okay, so about less than 60%, it's going up and down, but between 50 and 60% always assess the degree of coronary artery calcifications, and another 23% often. So, so why not always? Okay, maybe we can discuss this later. The next question is, how do you assess the degree of coronary artery calcifications in your lung cancer? Do you do it visually and globally? Do you use ordinal scoring? Do you use the Agatston score, or do you have another method? Okay, so most people are using the ordinal scoring, about 50%, and the visually and globally is also almost as common. Okay, so we ended up doing, actually it was for the purpose of this presentation, my colleague from my department at Hadassah, Dr. Dotan Cohen, who is the radiologist who is in charge of cardiac imaging in my division. And so he helped me do the Agatston score for this case. So you can see that whoever said that it's severe was probably correct, and the score is more than 2,700 with a percentile of 21%. So the point here is that you can also do the Agatston scoring. I think that not many people do it routinely on low-dose CTs, as we saw, but it is possible to do it. And then what would you recommend after you report the coronary calcium? What would you recommend? Would you recommend to consult a cardiologist, a family physician? Do you not give recommendations at all, or anything else? So for every case where you report coronary artery calcifications, or, okay.
I think you asked about this case.
This case.
Okay.
With a score that high.
Okay, I meant generally, but you, in this case, okay, let's settle for that. Okay. Okay. Still going on. So for this case, most of you, almost 80%, would recommend to consult a cardiologist. Okay, but also almost 1/4 of you thought that to consult a family physician. Okay, so I mentioned before the lung cancer, the National Lung Cancer Screening Pilot that we held. It was organized by the Israeli Ministry of Health, and we have, as I said, we have a national health insurance. So every citizen, every resident actually of Israel has a medical coverage, and there are 4 HMOs. So it was done together with HMOs, and we had standardized reporting. And also for the coronary part, we got advice from Dr. Shemesh. So of course it was in Hebrew, but I translated it. So for every report that went out, we also added this. Coronary calcifications or their absence are of great importance in the prognosis of cardiovascular disease and in the need to take statins for primary prevention. And then we had one of these options: no coronary calcifications, or there are severe coronary calcification, and it is recommended to consult a cardiologist, or there are moderate to mild coronary calcifications, and your family physician will consider the clinical importance of the coronary calcifications in the exam. And we also added these comments: using the current scan, a calcium score can be calculated according to clinical need. And for an accurate assessment of the risk, it is recommended to use the MESA risk score. So every report in our national pilot came out with this these comments. So now I have some questions for the panel. How do you, the members of the panel, report, or how do your radiologists report coronary artery calcification? And is it different between baseline and annual screening? So we start maybe with the radiologist. Matt, would you like to?
Sure. At my institution, we generally use mild, moderate, severe. It's just a visual/global evaluation. It's worked pretty well. In other words, we just put in our template, the calcium evaluation, and so everyone has to really comment on it, can't be left blank, which makes it very systematic for all reviewers, all radiologists. Difference between baseline and annual, no, we treat every exam the same way. We interpret mild, moderate, severe for every case.
Okay, Ella?
Very similar. It's a hard-coded field in our radiology report, so you can't sign the report without selecting one. Similar baseline versus annual screening. I think given Lodo's technique, in 1 year, it's very hard to assess interval change visually, so we don't report, let's say, look at it for interval change. I think one of the challenges that a lot of radiologists have is they're not looking in the EHR to see if, is some of that really a stent that you're not picking up, or a stent with a lot of calcification? So I try and recommend it, and I see it reasonably often that people are, say it's severe, but you know, if you just looked over here, it's the problem is you'd see they had a stent. So that's one of the things that people tend to miss.
And Rosemary?
Well, we don't have national screening yet, but in clinical practice, with more severe calcium, I would indeed use visual scoring, moderate, severe, put it in the conclusion of the report.
So all of the radiologists in the panel use the visual eyeballing, right? Okay, do the non-radiologists have comments regarding this? Non-radiologists,
I
non-cardiologists?
generally follow the report's recommendations. But yeah, I hold, sure.
And Sam, would you like to add anything?
Yeah, so we had a CT from 20 years ago when the person was 58, right? And I'm assuming at some point it became evident that there were coronary artery calcifications. And I'm assuming that at that time, they were not severe. So sometime before this last CT, that's when the conversation should have happened to evaluate the overall cardiovascular risk and to, in a shared decision-making conversation, decide whether statin therapy should have been started or not. I recently learned from cardiologists that you're not expected to actually have a reduction of the CAC score when you start statin therapy necessarily. Other cardiologists here may correct that, but that if you start, for example, lower dose statin therapy, and then you see in subsequent CTs that the calcification score continues to worsen, that may require a reconsideration to increase the intensity of the statin therapy. So would be interested in reviewing the whole sequence of how this happened. And of course, I understand that we are learning about CAC scores as we go, but this would be a great case to see all the serial imaging and how those conversations progress and what happens.
Okay, thank you. Any comments from the audience? Yes.
For the cardiology point there. So if you treat a patient effectively for lipid lowering, in fact, you can increase their calcium. We have data that
I also learned that.
so the intensity, the density, because Agatston is the weighted scale.
Right.
The density goes up, Agatston score goes up. We are working with an AI tool that we've developed to distinguish response to treatment versus progression of disease. And that is based on the area that is plaque is expanding, the ratio of the density to the area and some of this stuff. So seeing calcium score going up is not a bad thing. If you're treating it.
Unless I'm having chest pain and problems.
Of course, that's symptomatic population. We're talking about the asymptomatic population. but we need to treat based on, I wish Dr. Marin was here because he was pushing for it to come, the new guideline. I'm gonna ask Mike to comment on. We need to push for severity-based treatment. So if your calcium score is, 20, 30, especially if you're young, you have to be on a statin to get benefit from. But if your calcium is scored 300, 400, and you're 50, 55, your treatment needs to be maximum. We need to get you on
From the get-go.
on an LDL below 55. So, and with both of these, we will increase your calcium score over time. So don't expect calcium to go away. Expect it to get more dense, which we call it more stable atherosclerosis. So I think we need to bring that insight universally to the lung cancer screening colleagues.
Yep.
That calcium doesn't go away. Calcium can go up. Doesn't mean you're not doing your job or the treatment is not working. But hopefully, once we get FDA approval to separate response to therapy versus progression of disease, that will also shed more light. Mike, you want to?
Yeah, I mean, I think exactly what you said, Mort. We expect the calcium score to keep going up on treatment with lipid lowering. So its main value is helping guide the initiation. When do you usually, as you heard earlier, Dr. Marin say usually, and Khurram Nasser say that, we sort of try to treat it like cancer. Once you're positive and you have the disease of coronary atherosclerosis is usually when we initiate treatment. And then there is an element that the higher the score or the percentile in younger patients, then the more aggressive. So the guidelines do have sort of a precision guidance that higher scores where thresholds are, 0 to 100, 100 to 300, 400, and then over 1,000. There are lower LDL targets, and there we, add additional agents to get to those lower LDL targets.
So I have been discussing with some people around here that our coordinators and our team is spending now more time having these conversations with those that are screening, because we kind of had the long nodule management working efficiently, and that information was already becoming, I wouldn't say monotonous. It's not never monotonous. Every patient is different.
But you want it to become
Correct.
monotonous.
But then now our coordinators are learning, training in this other aspect of prevention and management. And it's helping us actually retain coordinators because they're not getting
Bored.
Yeah, exactly. They're learning more about it. They're learning more about it.
I just had a question for you. Once we get to a patient who's got moderate or severe calcium on CT, they're under treatment, like you said, calcium score can go up. What's the value if we're reading annual screening CT year over year over year? What should we or should we not be doing in reporting the coronary calcium? Knowing that it's going up, should we put that in our reports? Should we just keep saying severe, leave it at that?
Yeah, I think the sort of ordinal scoring or the category scoring, I think is fine. There isn't, the expectation is going to keep going up on therapy. It's not really going to change therapy. There are occasionally times where we're looking at sort of an absolute score to guide, because there are guidelines around when aspirin may be most helpful in addition to targeting lower LDL targets. And there, I'd say if you're trying to make that more precision decision, we should probably get a true coronary calcium scan and with quantitation. But yeah, I think once it's already at that level, it's just, as that patient could have very well been on statin therapy for quite some time.
Yes,
and hopefully
probably.
they were. And hopefully it's guidance to drive their LDL low. But go ahead.
If the CAC was 0, for sure, we would recommend repeating in 3 to 5 years if diabetes exists or modified risk factors like rheumatological disorders and so on. If CAC is not 0 and it is massive, like 500 and so on, if you have other reasons to bring them back, you bring them back. But there is a place like Mike immediately spotted. This, we with our eyes scored it over 2,000. some of these patients may actually have ischemia that they're not aware. So you send them to a consulting cardiologist, and then we could do more in terms of treatment because we actually can, alleviate some of the.
I agree 100%, but the way I understood the question is we're bringing them every year for annuals, right? What's the role of keep reporting the CAC or implications? And what we have done in our team is negotiated with the radiologists. We're not asking the radiologists to measure, how much more or how much same and what it means. Our team is having that conversation. So radiologists are still reporting it and the score, but then the conversation of what it means and what to do next is the lung cancer screening.
If your question was.
Okay, so
should
just,
Just a very.
I have many
Very brief.
cases that I
I was just
prepared.
gonna say, if your question was such, do I do more, just saying extensively, once this new AI comes out, we have something that's called 1K club member. Means your density went about 1,000 Agassiz score. Those are considered stabilized and more, less risk. There is a discussion, we don't have guidelines for it, but just FYI, the 1K club members are more protected, have lower risk. We're accumulating data. So if you have the ability to identify those, it's a good
Okay.
signal for your practitioner.
Thank you. There-
Okay, so we would like to move on. So just one quick
no,
comment by Javier
I had a
and
question, but
Dr. Semesh.
I'm gonna bypass it because we have to move on. I'll try to squeeze it in another case.
Okay.
Just
Doc,
hold your thought and maybe there's gonna be another opportunity, Joe, to talk, okay? Because otherwise we're not gonna, we have 7 cases.
Okay.
Yeah,
So-
sorry. That's all I do. I wasn't prepared for this.
Okay, so this is our next patient who is 63 years old and he has hyperlipidemia and family history, and his video is now running.
Oh, I think my question is gonna be better for this case.
Okay. Okay, so okay. So how would you grade the coronary calcium in this case? Okay, so this case and the next two subsequent cases are actually coronary calcium, low dose coronary calcium scoring. They were done for calcium scoring at my institution. Okay, so I think most people think mild. Okay, then the next question is, okay, we ran it, but we can go then back again to seeing it. Okay, okay, so look at it again. Okay, so did you notice anything else other than the calcium? Okay, so what, so if no, and if you saw something else, was it, you saw valvular calcification, aortic aneurysm, pulmonary nodule, or a mediastinal mass? Okay, so 53% of the people saw valvular calcification. Can we go back and we see it again? Now you have the questions in mind. Okay. Okay, so everyone is good with the previous,
You don't have aortic calcification there.
okay, so what do we see here, right? What do you see here? So my colleague did notice that there was this little paraspinal mass, right? So we did a PET CT. Then we did a needle biopsy. And the diagnosis here was lymphoma, follicular lymphoma, for which he was treated. And this was diagnosed on a lung cancer sorry, on a coronary calcium screening case. Okay, so would you like to ask your question?
No, no, let's first discuss it. Going back to the calcium, which is not important here.
I think in that case, probably people saw a little spot that was in at the origin of the right coronary that might have thought that that was valid.
I think it was in the ascending aorta. But many people didn't see anything, right? So I think the lesson from this is that we have to look carefully, right? And okay, I have some.
We probably didn't see it at the right speed, though.
And
You know, from.
Was it too quick for the radiologist as well? Okay, but next case you will pay better attention. Yes, yes, Fred.
That calcification is in the proximal left and proximal left coronary artery.
Yeah, it's a little high risk. But
In the calcium score, that would be the same number, but the fact that it's in the widowmaker location, does that show up in the reports?
Calcium score is always start for proximal to distal. This is almost when you study progression, that's what you are looking at. And mainly it starts in the LAD, the proximal part, and then it go to the distal. It's very rare to have distal without any proximal calcification.
Okay, so we go on, unless anyone has a burning question, we go on to the next case. This was also done it was low dose CT for calcium scoring.
You know what the score
Okay.
was?
We just, no, I don't know. Okay, this was all the previous case, this one and the next one were done it was actually in 1 month, and it was the same family physician who referred the patient, and they were really, really excited to find all these additional findings. Okay, so this is a 59-year-old male again with hyperlipidemia and a fatty liver. And let's see the video. Okay, so again, I would like to ask you to grade CAC in this case. Okay, 100% agreement. Okay, and the next question is if you saw anything else, we can run it again. Okay, so what other finding did you see? Was it a mediastinal mass, a pulmonary nodule, aortic aneurysm, or valvular? I think this one was too easy, right? The previous was too hard. This was too easy.
Just one person answered.
It was only one person? I didn't see. So maybe it was not so easy. Okay, so on this case, we did an MRI of the chest. And again, my colleague, Dr. Cohen, he was the one who read it. So his description was that there is a heterogeneous mass in the anterior mediastinum with soft tissue and cystic components. And his DD included a thymoma, which he thought was most likely, and also germ cell tumor. I have to go back. And this patient underwent thymectomy, and this was a thymoma with transcapsular invasion. And it was graded, as you can see here. I'm not familiar with this grading, but maybe Ella, you know it, right? A modified Masaoka stage 2B. So I think it was lucky that we caught it early. And this was because he underwent coronary calcium scoring. Okay.
Since we moved quickly through these two cases, maybe
Yes.
we can give Dr. Shanash the opportunity to bring up your comment that you had before. You want to say anything about? Yeah.
I just wanted to say for the progression of coronary calcium, that the most important thing is there any accelerated atherosclerosis? Accelerated atherosclerosis, when you see young patient or 40 or 50 years with a lot of calcium, then you say that there is acceleration of the atherosclerosis. And then sometimes, if you have the chance, like you have, to see it every year, then you see it when it's progressed very, very, very quickly. And then you say there is an acceleration of the atherosclerosis, because atherosclerosis, everybody has. The question is, what is the rate of the progression? And that whenever you see somebody with accelerated atherosclerosis, it should be treated very, 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 very intensively. And that's the notion. As for the how much it progress, we don't have any quantification to tell you what we have quantification, but we cannot tell you about the what is the threshold of the progression that you should treat like this or else. But if they changed category of risk, okay? But generally, I wanted to say it is accelerated atherosclerosis, the thing that you have to look for.
Thank you. Thank you.
I was just at 15%. If not treated, if the growth is more than 15%, is considered accelerated. But
That's
it's treated
when you're not on treatment.
when you're not
That
treated.
is critical, critical difference between being, once you're on treatment,
It's
that
totally.
data doesn't.
Okay.
Okay, so we'll continue to the next case. Maybe this will be of more interest to our cardiology colleagues. So this was a 54-year-old male. He was not a professional athlete, but he did lots of sports, running and cycling. He had family history of heart disease and elevated cholesterol levels, and he was referred to for a coronary calcium scoring. Okay, so let's see. Okay. So what other finding did you notice? Was it a breast mass, mediastinal mass, pulmonary nodule, or aortic aneurysm and aortic valve calcification? Okay, so again, too easy question. So as you can see, the diameter of his aorta was 46 millimeters, and also you saw the coronary artery calcification. So what was the diagnosis? Okay, so this was an incidental bicuspid aortic valve, which was really diagnosed from the coronary calcium scoring. So I think that after this case, I have some questions for the panel, unless you want to comment something in this case.
I was just going to comment, I do not see on most standard coronary calcium reports measurements of the aorta. And we started including those at like standard time points, I think probably 8 or 10 years ago. Diameter of the root, comment on the degree of aortic valve calcification, and then diameter of the mid-ascending and mid-descending aorta. It's just like standard. And we're going to systematically look back at what was the impact of all that data. But it's not required in most coronary calcium reporting to include any specific measurements or comments about the valve or the aorta.
Are you talking about a calcium score scan?
Yeah, on a dedicated coronary calcium CT.
Because
We
it's
put that.
not isotropic, so to do a double oblique measurement would be a bit tough.
Even if you take the ascending and descending where it's at its most vertically oriented in the chest, and use that to try and avoid the obliquities where we make the measurement.
Because that probably would be tough as the
Okay.
root. But,
Okay, so now we go back to lung cancers. Sorry, no, this case was also a coronary calcium scoring. Low dose. Okay, this is actually Dr. Sham's case, patient, which he referred to me. So we have Tel Aviv, Jerusalem collaboration. So let's look at this. This is a 70-year-old female. She's a former smoker with 20 PEC years of history. She stopped smoking 40 years ago. Okay. And Okay, so let's do it. So you see that the field of view here is small. Okay. Let's continue. So this was the mediastinal window. This is the lung window. Let's look at this as well. Okay. So what other findings? So I'm not asking you about the aortic valve calcification. So what did you see? So
Dr. Harkin responded to that one.
Dr. Harkin?
He's 100%.
Okay.
Calcium score.
So most of you saw the nodule, and I think it was very lucky that Dr. Shemesh saw it because it was, as you see, on the edge, almost the end of the examination. And so if another cardiologist was reading it, I hope that anyone could pick it up. So he was referred to me. I asked him to do an entire CT. This was actually done. This was done in Tel Aviv, but then I presented it in our multidisciplinary tumor board, and we decided to repeat it to make sure it was not infection. This was 1 month later. And then she had a segmentectomy of the right lower lobe, and this was minimally invasive carcinoma measuring 2 millimeters with adenocarcinoma in situ. And in the background, there was emphysematous changes, even though she stopped smoking 40 years ago. So this was really an incidental, as you can see, lung cancer detected on coronary artery, coronary artery calcium scoring. Just to show you that another incidental finding, this was a lung cancer. This is a case from our national lung cancer screening project, and I was given by my colleague, Dr. More from Tel Aviv. And this was a male incidental breast cancer in a male, which was detected. A man who underwent lung cancer screening. So these are my questions to the panel. Who do you think should undergo CAC scoring? Who is responsible for reading these exams at your institutions? Are these the radiologists, cardiologists, or together? And do you think that these exams should be combined in view of what I show you today, that we have, there is some overlap and there are some incidental findings that may be detected in either of those findings? Should these exams be combined? So we start with maybe Rosemary. Would you like to?
I think one of these comes back to what Martise said about what do you call screening or not. In the Netherlands, calcium scoring is only indicated in discussion of the patient with the GP or the cardiologist regarding the decision to start medication in an intermediate risk category. So that's not screening, it's a clinically indicated scan to determine whether treatment is indicated or not. When we're talking about screening, I don't think at this moment we have recommendations for screening an entire part of the population. In view of the fact that, as far as I know, nearly 2/3 or more of the US adult population is actually at intermediate risk, you could, of course, start considering screening because you don't probably have very little reselection to do, but that's just maybe an idea.
Yes, we've
Sure didn't hear that.
So we follow the guideline concordant recommendations. Most of our coronary calcium scoring comes from our cardiologists. I'd say a small percent of it comes from primary care. So they're the ones for ordering it. We report it as far and recommendations accordingly. But when it comes to doing lung cancer screening and coronary calcium together, I think an approach that you could take now without, thinking about dual types of protocols and so on, is there are people who come for calcium scoring CTs who are eligible for lung cancer screening. Just like there are women who come for screening mammograms who are eligible for lung cancer screening. So a very easy starting place is to look at your patients who are getting scheduled for coronary calcium scoring, see if they're eligible for lung cancer screening, and make sure they get the images you need for both at the same time. And that would be a win-win for both, an easy win-win.
Okay, Dr. Harkin, do you have any comment?
I totally agree with what you just said. I think that logistically, the logistics is the challenge here, right? Because it's going to depend a lot on who's either ordering the scan. So ideally, this would be primary care, right? And they're going to know if the patient is lung cancer risk, breast cancer risk, cardiac risk, right? That's the one person who knows all those risks, right? So ideally, it would be coming from primary care. And I'll let David and Claudia correct me, but I think most of the screening does not come from primary care here. I think a lot of it comes from pulmonologists. I think a lot of the cardiac scans come from cardiologists.
I see your point. So we funded a study from the Cancer Society Roundtable. Bob Smith was one of the investigators, and we funded 3 sites to look at women who were scheduled for screening mammography. And they went into the medical record, they identified people who are eligible, and then they reached out to their primary care physician to say, hey, we know your patient's coming for screening mammography. It looks like they're eligible. Is it okay to proceed? And then we coordinate, and they coordinated accordingly.
Yeah, and that's what was going to be my next suggestion is to leverage the medical record for this sort of thing. And I think we're not taking anywhere near the degree of advantage we can from the medical record for this sort of thing. That if something pops up here, there should be a best practice alert. Say, hey, do you want to extend this to lung cancer screening as well for your cardiac score? Your patient's a smoker for X amount of years. And I think that would be really wonderful because I can tell you it's very frustrating. We get a lot of referrals. I'm an interventional pulmonologist. I get, can you biopsy this nodule? And it's on a cardiac scan. And I'm seeing, if I'm lucky, I'm seeing 50% of the lung, right? Not even that often. So now, you need another CAT scan. I just got a CAT scan, and it would be better care of the patient, and it would be less frustration for all the providers, I think, if we could figure out how to do this in an effective and efficient manner and get it right on the first scan rather than needing multiple scans for these patients.
Yeah, and I mentioned something earlier in the week about let's widen the field of view to include the whole lungs on these calcium scoring exams. So I just pulled up the paper to quote the statistics that was done, where 67% of nodules larger than 1 centimeter are missed by keeping the field of view small. And that's just in that part of the chest without filling the upper lobes where there's the highest rate of lung cancer.
Well, along those lines, we find in our incidence of lung nodule program, a lot of nodules on coronary calcium CTs. And the question always arises, this one, we saw, you did a CT scan at 1 month because, okay, there's a possibility of infection, but how about a more solid, not that clear nodule? When do you do the full chest CT scan? Do you do it right away? Do you wait 3 months, according to, in our case, the I-ELCAP protocol? What do you do in those cases? And I would just throw out that question.
Yeah, it's a really good question. It also applies to, say, somebody in an abdominal CT and you got a little bit of the lungs, or a neck CT, you got a little bit of the lungs, shoulder CT, and so on. So we got together a multidisciplinary group at our institution with pulmonary medicine, interventional pulmonary, thoracic surgery. And, we sat down and had a discussion about what would be best. And we also heard from the abdominal radiologist and the neuroradiologist. And so what we said is if you have a 6 millimeter or larger nodule of any kind, because we want to make it simple and easy to implement across all these different specialties in radiology, 6 centimeter or larger of any size, we'd recommend that you have a follow-up in 6 months. Now, that's not written anywhere in any guidelines. That was our local multidisciplinary attempt to try and figure out a threshold of what to do next.
So we kind of do the same thing, but we find a lot of times that we're trying to, the patient is anxious about that. You have a nodule, and what about the rest of the lungs? And so it's difficult to reassure a patient with that when they're anxious.
Matt, would you like to comment?
Yeah, so at our institution, if we do find an incidental nodule on a calcium score, for example, we don't immediately do a full chest CT. Depending on the size of the nodule, it'd be 12 months if it's a tiny nodule. not immediate. So very similar to what you do. Although yours is 6 months, we would even prolong it to 12 months if it were, let's say, a 4 or 3 millimeter nodule. That being said, I've had the fortune of working both in the East Coast here in New York City at Cornell, Mount Sinai, as well as in the West Coast in Seattle, where I'm at right now. And the population that undergoes calcium scoring is quite different. Here in New York, both Cornell and Mount Sinai, we routinely would perform a calcium score in addition to a coronary CTA. Whenever a coronary CTA is ordered for chest pain, we would do a calcium score on every single patient, no exception. So we do both. We essentially do the coronary CTA and bill for that, and we provide a free calcium score. We scan it, but we don't charge for it. And everything's fine. We bill for it, no problems. And these are, again, symptomatic patients. Now, there's a separate group in New York that we scan where they need a tiebreaker. It's abnormal labs, but they're not sure what it means. So we get a calcium score to decide to treat or not. And so we have a dedicated calcium score population as well. Now, in the West Coast, we actually cannot combine calcium score and coronary CTA. If we do both, even if we say the calcium score is free, the insurance will deny payment for the coronary CTA. So we cannot do both. We can only do coronary CTA, that's it. We cannot add a free calcium score. So it's very interesting. Different practice patterns. I don't know, in Seattle, we could not add it. We tried adding it. We had problems with billing and then we decided to stop.
There are two CPT codes. There's one for coronary CTA alone, and there's another for coronary CTA plus calcium.
Yep.
Really? That's crazy.
Yeah, at Stanford, we get both the calcium score and the CTA.
Together. So we struggle with that in Seattle.
So I'm curious about finding a nodule. What is, from your long studies, the statistics on concomitant nodule? So if you find a nodule in a calcium scan of, say, 5 millimeters, what's the chance of another nodule in upper lobe? Is there studies to say, like, usually it's more than just, or is it the same as if you didn't have the chance of?
I haven't gone back and looked at it yet since we started that, but it's a good idea. Sure.
In Arizona, it's very common. In Arizona, we have a lot of nodules. So a incidental nodule that nobody was looking, low risk for lung cancer, etc., is usually 20% or so. People will have multiple nodules. But as far as the reporting of the CAC score, everything we do at the Phoenix VA is the I-ELCAP protocol. So we use the standardized CT reporting from I-ELCAP. And our team orders all of the screening CTs. So the radiologists, when they get our order, that's the reporting. When there is an incidental lung nodule found, they do a quick evaluation. If that person is likely to meet criteria for lung cancer screening, we take over that person. The radiologists do exactly the same reporting. If it is a very low risk for lung cancer, they do the Fleischner Society guidelines, and they don't necessarily do the CAC scoring in those. So,
What practical issues the cardiologists avoid is because they have to hire a radiologist to read the lung. And they're now pushing hard lung, say, can you please add a lung nodule report to this so we don't have to go hire a radiologist for that. There is, funding and financial issues for cardiology committee to be, fully on board with what you're doing because the hospital doesn't, or facility doesn't want to hire another radiologist, push them to limit the field of view,
Right.
so they don't have as much like.
But
And the
that's
AI
not good
radiology
healthcare,
software that
sorry.
we're gonna be testing, it's gonna be the same standardized reporting of I-ELCAP form, so it will include CAC scores and all of that.
So are any of the cardiologists reading these studies by themselves without radiologists, or everywhere radiologists are reading them?
For CAC scores, you don't need radiologists. You just have your technician.
So would you have identified this lymphoma or?
Oh, my goodness.
They're gonna have to send it to a radiologist, and they're avoiding it, and that was the course. Now,
We are fighting that, but that's what's happening in some places.
We'll set up you can set up an incidental lung nodule program and
So it will be reviewed.
AI will detect it.
Yeah.
I see a nodule. I mean, what I've always learned is that the radiology examination is the entire examination, including the entire field of view and the topogram.
Yes.
Sometimes, so always review the topogram, because if there's a tumor in the upper lobes and it's larger than, they say, 1 or 1.5 centimeters, you'll see it. You can't miss it. There have actually been some legal cases in the Netherlands where the topogram was overlooked. So always look at that at least for a sec.
So I was gonna say at the American Society of Nuclear Cardiology, it was just that last week. It was a room full of cardiologists and we're talking about lung nodules. And I did a survey of the room and nobody in the room extended their field of view beyond the heart, which again, I commented on earlier. And none of them were using AI or any tools to help them find nodules. And I think they were all alarmed at the number of nodules that are being missed, the potential litigation. And they were just like, it seemed like a plea for help. You'd like reading the faces and people, I think, were shocked at how big the problem is, the impact of early detection. I'm very fortunate to work with cardiologists who we've embedded the AI for lung nodule detection measurement on their tools, and we're always available to talk to each other. And so it's a really good working relationship. But we have AI running on all the SPECT CTs and PET CTs in nuclear medicine.
Okay, thank you. Okay, so we continue to the next case. So this was a 65-year-old male heavy smoker who had recurrent pulmonary infection. So this is the study that was done in December 2022. So we also have I have a video for this. Okay, and my question. What would you recommend? Oh, sorry. So the options are antibiotics and 1 month low dose CT, 3 months follow-up, 12 months follow-up, bronchoscopy, and needle biopsy. So it seems like there is a tie between the antibiotics and 1 month low dose CT follow-up and bronchoscopy, and antibiotics is the winner. Okay. So actually, this is an outside case, and I'm not sure what they did, but the patient then came back a year later. So here you can see this is December of 2023, and you can see this lingular collapse. You can also see it on the chest X-ray, PA and lateral. And this was the CT at this point. Okay. So what would you recommend at this point? It's the same options, antibiotics, 3 or 12 months follow-up, and bronchoscopy. So here I can't see how many people voted. But... Okay, so most people would go for bronchoscopy. So can I ask my pulmonary colleagues to comment here?
Tim?
Sure. So the first scan shows endobronchial obstruction, I think, in the lingula, and some dense infiltrate behind that. Maybe a little bit of volume loss there, and some bronchial wall thickening. To me, that's enough to do bronchoscopy. I think giving antibiotics and doing a 1 month follow-up is maybe reasonable if the patient is minimally symptomatic. If the patient's asymptomatic, I think you got to do a bronchoscopy because then you're really concerned about a malignancy in there. If the patient were reluctant and wanted to get antibiotics, I guess that would not be terrible, but I think he's still going to need a bronch a month later. So, and you want to avoid the situation that you just showed, which is a year later. You have complete obstruction of the airway, and now you have to go in and probably deal with a more advanced problem, malignant or not. I mean, there can always be a benign tumor there, or a carcinoid or something blocking the airway, a foreign body, and bad bronchiectasis behind it that you can't see because of the volume loss. But you have to know what's going on inside that airway.
Yes, Matt.
Quick question. What if this were an inpatient? When do you start with respiratory therapy versus go straight to bronchoscopy?
Yeah, I mean, the chance of a mucus plug being coughed out that's causing that degree of an opacity, I think, is pretty slim. You know, I think even if it's just a mucus plug, this is a sort of mucus plug that takes me 20 minutes to suck out, you know. So.
Okay, Sam or? Javier?
I agree with everything.
Me too.
Okay. So what do you think the diagnosis was? Hmm? And what do the radiologists
Yeah,
think?
exactly.
So then I think you try to sample something. So first of all, it's hard to believe that the airway would be wide open, to be honest with you. But I would at least do a BAL. I wouldn't probably do a transbronchial biopsy if I didn't see anything inside the airway, but I would do a BAL, look for infection, MAC in particular, and see if there's any Leydig cells in there. But I would be shocked if that airway is patent on the bronchoscopy.
So.
But it's like Tim
can I-
said, if he was symptomatic and having acute problems, then you're okay to go with the antibiotics and short-term follow-up. But if the patient is in front of you with minimal symptoms and have these findings, then you really want to know what's going on as early as possible.
So we had the recurrent infections, as I said, recurrent pulmonary infections.
So I think, from here, I didn't see any obstruction of the airway, but I did see what looked like linear atelectasis if you look at it on the sagittal view probably. So I probably would have done 1 month in antibiotics before I do a bronchoscopy. However, if you do see obstruction, that's another issue.
And if you see in 1 month and then no change,
Then
you wouldn't say, let's wait another
well,
3
then,
months or 6 months and see if it stayed. I mean, we see a lot of cases, for example, that have chronic middle lobe or, and we don't keep chasing it. After a while, you stop. These things are always, it's always a little
The
gray.
middle lobe is different.
In screening, I try to do as little as possible in a certain sense, because otherwise you're chasing too many findings.
This is the worst case for Friday afternoon.
We're being told, we're being told that the patient is symptomatic, has repetitive infections, so just that, I think, you
Yeah.
would, some point you would have to go in and look.
This was a lot of atelectasis, but it gets, if it's not quite this much and, do you still go and bronch them, that kind of thing. There's a point where it gets very gray.
I thought that first scan was pretty eye-catching.
Yeah.
Okay, so let's see what the result was. So he did undergo bronchoscopy, and there were fragments of bronchial wall infiltrated by squamous cell carcinoma. So unfortunately, this
Good,
was-
Dr. Harkin was his doctor.
Yeah, okay, so we have one more case. I think we have, okay, so I actually have some questions for the panel, or should we go to the next case? So let's do quickly the questions to the panel. This was a discussion in a recent meeting that we had with pulmonologists, and my question is, do you think it is appropriate for radiologists to recommend antibiotics and follow-up, or should they go through a pulmonologist? Let's do this question.
Has the radiologist examined and talked to the patient?
No, just according to the.
That's kind of my point. So you can't manage a patient just based on a CAT scan.
Let's say it's a screening case. We do it, right? We recommend the antibiotics and follow-up. Do you think it's appropriate, inappropriate?
So we discuss similar cases every Tuesday.
Okay.
And after a certain period of time, the radiologists participating in those meetings get a sense of which patients this is appropriate for them to make a comment like that, and which patients they call directly and say, how should we proceed with this one? So there is a little bit of clinical judgment on how you stick your neck out, recommend that, or you discuss the case before writing something like that.
Okay, because this is a question for Ella. It's one of the Langretz categories, right? Category 0, you recommend antibiotics and follow-up. So
Yeah, I think, there's this misnomer that everybody who comes for their screening CT is asymptomatic. A lot of times they get their screening CT now, the order's placed, it's scheduled for a year out, and maybe they were asymptomatic last year, but now they've just popped up. They haven't seen their primary care physician in a year, and they may have symptoms. So I don't think you can fall back on saying, oh, they're asymptomatic just because you're reading a screening CT. Doing due diligence, looking in the EHR, seeing if there's any information. We've thought about having our CT techs ask the patient about a few symptoms before they do the scan to evolve some, to catch some of these cases where they probably have infection, or you can see it on the CT scout. And so, well, why are you doing the scan when you know you're not going to be able to clear a good chunk of the lung parenchyma? I've gotten a little cautious about the, recommend antibiotics to a CT in a month. I do it sometimes when it looks like a more typical pneumonia with air bronchograms and so on. But when something like that is collapsed, I usually, I might say, consider antibiotics and referral to pulmonary medicine and not just say that I know what the best thing is to do.
So you wanted to comment?
No, I was going to say exactly that. I think our radiologists here at Mount Sinai are pretty good in adding that caution. Consider an infectious process, inflammatory, and don't. I really, it's a long time since I've seen a radiologist say give antibiotics and come back in a month.
Yeah, but I think there's a difference too between the other case with that little right lower lobe nodule.
Right.
Okay, antibiotics there, no problem. This is a collapsed airway. I mean, you can't just, I don't think the radiologist should be putting that in the report.
Correct.
Okay, so last case, we have 8 minutes. So this was presented at our multidisciplinary tumor board 2 months ago. So this is a 71-year-old female smoker, active smoker, and she had this nodule almost 3 by 1.5 millimeter subsolid nodule with a, here it looks more like a dilated bronchus, but it was really a cystic component. And as you can see, it was really unchanged between 2022 and 2024. And so what would you have recommended in this case? 6 months follow-up, 12 months follow-up, EBAS, or what do we have? Let's see, or needle biopsy? Okay, so please note that 0% people chose mediastinal or hilar lymph node biopsy, but this was actually what was done. Although,
We didn't see that.
no, but there was no uptake. They did the PET CT, there was no uptake, but they thought that there was an enlarged right hilar lymph node, and they biopsied it. And it came back small cell carcinoma. So now there is a question what to do. So I'm asking for your help. What would you have done here? 12 months, low dose follow. Reevaluation of the pathology specimen, EBAS with repeat lymph node biopsy or needle biopsy of the right lower lobe. So I see it's going up and down on this. So most people here think that needle biopsy. So, okay, so do you think it's going to be small cell in the, so, okay, so.
There might be 2 different cancers.
Okay. So I want to ask the panel, we have only 5 minutes, but do you have regular tumor board conferences, multidisciplinary tumor boards? How often do you meet? What are the participating disciplines and which discipline hosts the meeting? How do you record the discussions? What do you do if there is disagreement? And the final question, if you think that we should have similar conferences with the cardiologists. So let's start, Rosemary, from your end.
Yes, we have a weekly tumor board where, well, 2 actually. One is for the local, for the university hospital cases, and one is for the region, where we give second opinions together with the clinicians from the center, the local centers. We have pulmonologists, we have pulmonary oncologists, radiation therapists, surgeons, pathologists, and radiologists, and nuclear medicine specialists. Let's see, which discipline hosts the meeting? The pulmonologists, and there's a digital recording and notes of the meeting prior or after the meeting. Disagreements, well, we resolve disagreements at the MDT, so we don't stop until we've resolved the issue together. That's what normally happens. And Yeah, there are, of course, hard teams for all kinds of complex cases. In my own hospital, usually the radiologists are not there, involved only in specific questions.
Yeah, pretty similar. We have weekly tumor board.
I didn't ask, how often do you meet?
Weekly,
Weekly,
every week.
okay, so 2 conferences per week.
So we have a Friday tumor board, the end of the week. It's gotten to be 2 to 2.5 hours long with lung cancer screening on top of the prior lung cancer nodule and lung cancer diagnostic cases. It's all the specialties you recommended: radiology, nuclear medicine, pulmonary, thoracic surgery, social work. The APPs who work in the cancer program and the cancer navigators and the surgeons and the pathologists. The only people who stay the entire time are the radiologists, because we're there for each and every case. The surgeons come and go with their case volume, but there's usually always somebody there. And the oncologists come and go when they're talking about their presentation. So because it's gotten so long, it's gotten burdensome that way, and people can't really afford to spend 2 to 2.5 hours together on a Friday. The discussions used to just be like somebody was there to take notes, but now we use an AI tool. So they send out the minutes and say, hey, reminder, this was created by AI, send in any, addendums you have for the cases that you presented. So it's made it a little bit easier. We don't leave without a disagreement, just like you said. Sometimes there's a choice 1, choice 2, where discussion with the patient preferences are going to be really important. It's all our oncology tumor boards are held in the cancer center as the convener. So and we're a multidisciplinary program, so it's not really a discipline, it's the cancer center that hosts all the tumor boards. We have a lot of cardiac conferences, from the TAVR conference to the rest of the structural heart conference to the cardiac cath coronary CTA correlation conference, to the cardiomyopathy conference, and we have a cardiac oncology conference with 2 other institutions for cardiac tumors. So we do an awful lot of conferences. They're extremely educational, but you can imagine that it's a great strain on everybody to be able to participate in so much, but they're great learning opportunities.
Feel overwhelmed listening to you.
We don't have one for preventative cardiology, things like coronary calcium. We don't have that kind of a conference, if that was the intent of the question.
I guess you should.
So at the University of Washington, we also have a weekly tumor board, and we have a separate weekly nodule board. So tumor boards for patients with known diagnosed cancers, whereas the nodule board would consist of these unknown difficult nodule cases. The participants typically are for the tumor board would be oncologists, thoracic surgeons, pulmonologists, and radiologists. For the nodule board, no oncologists involved because these patients do not have a diagnosis of cancer yet. In terms of the recordings, we generally do not record any conferences with potential HIPAA information, in which case all these cases do have HIPAA content, and so nothing's recorded. We're concerned that if you have a library of videos, if something gets hacked, you might be opening yourself up to liability. So anything that's HIPAA is generally not recorded in some video. And that's true even during the pandemic era. We would have Zoom conferences, but if it's HIPAA, they're not recorded. Generally, there's not much of a disagreement in terms of what to do next, because the different specialties would give their opinion, and then the primary care provider, whether it's a pulmonary medicine physician or a family medicine physician, will just take the different inputs and decide from that, and also take the patient's opinions into consideration, of course. And we do have similar cardiac conferences. Specifically, we have a cardiac CT and MRI conference. These are the cases where someone might have an unknown cardiomyopathy and they might not know is it sarcoidosis or myocarditis. What should we do? So we do have something similar for that.
Okay.
We have a multidisciplinary lung cancer screening conference on Tuesdays, and now we have a cardiologist part of that conference. So we discuss both nodules, but now we're also discussing CAC scores and how to learn manage. That's where we teach our coordinators on how to develop the language. We're measuring workload also to see, do we need 2 separate conferences or can we keep it like that? Sometimes we join the incidental nodules program people as well to discuss other interesting cases. There is a tumor board conference on Friday mornings. It's also very long and it can get prolong and prolong. And we only attend those when we have cases that were diagnosed from the screening program or the incidental nodule program, and we're there to learn about what happened with that case. All conferences are recorded in Microsoft Teams, so there is a library of recorded conferences available to go back and make sure that, you know, if anybody wants to know that things were done appropriately. And disagreements, you know how it goes. There has to be at least a consensus, and then we will follow up on next steps. Somebody is responsible to come back with some answers. And cardiac conferences, right now, we just have cardiology join the lung cancer screening and discuss CAC scores.
Okay.
Tim, you have
Martijn?
2 seconds.
So we have two tumor board conferences here, one on the main campus based here. And then there's a second one for the other hospitals in the system. Although the main campus one is on Zoom, so a lot of people do join us from the other campuses. We have everybody that it was mentioned, the surgeons, the pulmonologists, the radiologists, pathologists, radiation oncologists, medical oncologists, and a lot of PAs. I think that's pretty much everybody. Both of the tumor boards meet weekly. The one on the main campus is hosted by thoracic surgery, and they kind of run it. We're encouraged to submit in writing the cases beforehand. There's a template that we use, and those are saved. I think that somebody's kind of recording what happened, what the outcome of the conversation is about those patients somewhere, but I believe it's all paper recorded. We do resolve disagreements at the conference. We really try to come out of there with a consensus, and I can't really comment about the cardiac conferences.
Okay.
I was
so-
just going to add, sort of
Yes.
from the cardiology standpoint, right, we, as Ella said, we have many cardiology conferences that are multidisciplinary, including radiology across all the different sort of cardiovascular diseases. I'm not aware that at Stanford that we participate with, say, a lung nodule group. We do have a regular preventive cardiology clinic that David Marin oversees that, you know, talk about complicated cases, but we don't view sort of coronary calcium score as a sort of complicated issue for us, but I could see helping in, you know, the low dose CT. The other thing that, and I know I'm supposed to stop here, but, you know, this issue of screening, and when one of the things I've wanted to start advocating is, you know, if somebody has a heart attack or is diagnosed with lung cancer, do you do an M&M that looks back and say, you know, how did we miss that? Because at this point, heart attacks should be preventable. And so, you know, I sort of encourage looking back and saying, you know, where was the opportunity missed to prevent that?
We have had a couple of those, and the main reason is difficulty to quit smoking. So you can do everything else that you want, but when people smoke a pack a day and they cannot quit and they're under stress, things happen.
Yeah, we don't do it for the cardiovascular events, but we do it for all the cases that come with lung cancer. Any imaging in our system or the ones that we can get through Epic, we do look back and see, you know, was there an opportunity? Pardon me? It's, if I get the outside images, it will be in my report.
Okay, so thank you very much. Thank you for the panel.